years. I'm currently doing my SAMP in ENT in Aintree. So, and I've got an interest in ENT. So I think it's hopefully will be an interesting talk for you. And for whoever watches this, if anyone watches on the recording, can you, is this definitely, can you see my screen at the moment? If I do that,
yep,
you can see it. Okay, cool. Okay, so the topics that need to be revised for finals, let me just move this out of the way. So this is a list that one of my friends made last year of all the ENT topics that can come up in finals. And I'm going to cover a few of these today. So hearing loss, tinnitus, vertigo, facial palsy, cholesteatomas, acoustic neuromas, otitis media, so that'll be acute otitis media, otosclerosis, BPPV, vestibular neuronitis, labyrinthitis, and Meniere disease. So it's a lot, but I find that with ENT, with finals, they don't ask you very complicated things. They just want to know like sort of bare minimum about many different topics. So that's what we'll be covering. So we'll go straight into it. So hearing, and if anyone has any questions, you can put them in the chat. I can't see the chat, but hopefully Monica will tell me.
Yeah, if anyone says anything, I'll read out.
So. Yeah. So hearing loss is broken up into two main types. You have conductive and sensory neural. And the easiest way to sort of break these up is to, if you think of the anatomy of the ear. So I like to think of it in, I should use my mouse so I can actually show you. So the external ear is all of this. It's from the auricle, so this and the pinna, going through into your ear canal and then to the tympanic membrane. That's all external ear. Middle ear is everything in the middle down the eustachian tube. And then everything beyond this in the promontory is inner ear. So cochlear, semicircular canals, and then your vestibular cochlear nerve. All of that is inner ear. So the way to distinguish whether something is sensory neural or conductive hearing loss is you could do this. So everything on the right side of this yellow line is any disease process that happens here will cause a sensory neural hearing loss. And sensory neural hearing loss is caused by inadequate processing by the end organ of hearing. So either the cochlear, so this snail-like thing, or poor transmission by the nerve. So this is actually more than one nerve. There's the cochlear nerve here and the superior and inferior vestibular nerve. Okay. And then any disease process that occurs this way out. So this could be anywhere from the ossicles. So that's the malleus, the incus, and that's the stapes. So anywhere from there out through the tympanic membrane would likely cause a conductive hearing loss. So this is a problem with sound transmission to the inner ear. And the way sound is transmitted normally is you have this pinna and the whole auricle. Its goal is to direct sound into your ear canal to then cause a kinetic energy change to vibrate your tympanic membrane, which would move the ossicles, cause endolymph, which is fluid in your ear, to move. And then these hair cells pick up that fluid shift and then convert that into electrical energy. So it goes kinetic, chemical, electric energy in your ear. So now that that's a bit of a basic rundown of the two types of hearing loss and the actual process of hearing, you can then further subdivide your conductive and sensory neural hearing loss into congenital causes and acquired causes. So when you think about it, it's the same as anything in medicine. You can just think anything congenital is anything that's you had since birth that can cause a problem in that process from the ossicles outwards. So this is something like having atresia of your auditory canal, which means no sound can actually go in. And acquired things as like wax, or like fancy name of that is cerumen, otitis externa, any foreign bodies. There's always interest in foreign bodies that people seem to manage to get in their ears. Congenital stuff for sensory neural is, or any kind of infection really that will affect the nerves. And then acquired is the same sort of thing. So trauma or infections, anything that can do damage to your nerves and beyond. Thing to note is if someone has a sudden sensory neural hearing loss, what's important to do is confirm it with an audiogram and give them high dose oral steroids. And you burst and taper, so it means you give them a high dose and then you slowly wean the dose down. And you also want to do an MRI with contrast of the internal acoustic meatus, looking for a vestibular schwannoma, which is something we'll talk about in a short while. see if I can change the slide. So tinnitus, it's an involuntary perception of sound. It originates in the head, and it's not attributable to an external source. So there's no known source for this tinnitus. It's not actually a disease in itself, it is a symptom. And it's the etymology of the word, it comes from the Latin tenere, which means to ring. So you can divide cause of tinnitus into objective. So there's an actual disease process going on. So it could be something like your temporomandibular joint, you have dysfunction there. So it's like you actually have unusual movement, and then that causes a sound translation into your ear. Or any other things such as problem with your carotid artery. So the carotid artery, the internal carotid artery lies just inferior to your middle ear. So if you have a problem with that, obviously I can imagine that causing hearing problems. Or subjective. And subjective can be further subdivided into pulsatile and non-pulsatile. So pulsatiles, I'm sure you can imagine, is things that affect your blood in some way. So if it's on one side, it's probably going to be an aneurysm or a vascular malformation. A glomus tumor is it's a tumor of your carotid artery. And if it's bilateral, it's probably going to be more something whole blood related, like anemia or a drug cause. Non-pulsatile, you have unilateral again, so like it could be noise induced, so you stood really close to a speaker, for example, or a tumor like a vestibular schwannoma. And if it's both sides and non-pulsatile, then it could be something to do with particular drugs or old age or other disease processes, which we'll talk about. Last one of these might be a bit tedious, but it's good to have a sort of a method to break down all these causes, because you do get asked this kind of stuff in clinic, and it's important to know the different causes of these important ENT pathologies. So vertigo or dizziness. So the true vertigo is when you have an illusion of rotatory movement. So it's just sort of you feel like the world's spinning or things are spinning around you. And then dizziness can just be lightheadedness or someone being unsteady. That could just be due to volume depletion, for example. There's two types of true vertigo, or two causes. The central vestibular dysfunction, which we're not going to talk about today. That's all the stuff that happens inside your brain or inside your skull that isn't relating to the structures of hearing. So this could be, you could have a bleed somewhere in your brain or meningitis, anything like that. But what we're interested in is the peripheral vestibular dysfunction. So this is all the conditions, or some of the conditions that can cause common cause of vertigo. Okay, so next, this is a very busy slide, but this is talking about facial palsies. So the one that we'll all have heard of is a Bell's palsy, which is when there's no known cause, but they usually think it's normally viral, but it's a cause of a problem in your facial nerve to become inflamed, which means the facial nerve doesn't work effectively. And normally what the facial nerve has a few functions, such as controlling the muscles of facial expression, controlling the muscle of eye closure, the orbicularis oculi. It has a nerve that supplies sensation to the anterior 2/3 of your tongue. And it also supplies a small muscle in your inner ear. So this is one of those things that people can mistake for a stroke and say this could likely, because this person obviously on the right hand side has a facial palsy because they're trying to lift their upper lip up, and you can see good creases on the left side, but it's completely flattened on the left side, or the right side, sorry. So how you distinguish between this and a stroke is when you have a lower motor neuron condition that affects the facial nerve, for example, this, like a Bell's palsy, you have a disease process here. So you're affecting both the upper and the lower side of the face. So the forehead isn't spared, which is something I'm sure you'll have come across before. When you have a higher lesion, because your forehead has a nerve supply from both sides, so both left and right hemispheres, then even though you cross out this pinky purple side, you still have this side which decussates and then still supplies that side. So when you have a stroke, you'll have forehead sparing, which is something important to remember. And when you have a lower motor neuron disease, forehead won't be spared. This is some of the things that the facial nerve does. So some of the suppliers, so it supplies lacrimation, so the ability for your eye to water. It's the chordae tympani, which is the thing that supplies sensations, the anterior 2/3 of your tongue. to the muscles of facial expression. And then the last one is to the stapedius muscle. So this is important because you get, with a Bell's palsy, you get a thing called hyperacusis, which means you have increased recognition of louder sounds. So it means it's more painful for you to hear everyday things such as like doors opening and closing. Patients will complain of it being really irritating and it being really loud on that side that they have their palsy. And this is because there are two muscles that when you hear a very loud sound, they contract. So one is the tensor tympani muscle, which is here, which is controlled by a branch of the trigeminal nerve, which what it does is it contracts here and pulls the tympanic membrane medially. And it means that it stops the heavy vibration when you hear a really loud sound. It sort of weakens that, it dampens that change. And there's also the same with the stapedius muscle. This is supplied by the facial nerve. And what this does is this pulls the stapes so that it doesn't have as much kinetic energy when you hear a very loud sound. So when you hear these loud sounds, normally these two muscles work together to dampen it. But if you have a palsy of the facial nerve, this muscle isn't working properly, which means you hear all these louder or even normal sounds you normally recognize as being of a normal decibel to be very loud and irritating to yourself. Okay, so next thing is a vestibular schwannoma. So this is, we're straying a lot in this area today. It's a lot of ear stuff and sort of, yeah, I find it interesting. Hopefully you do as well. But the vestibular schwannoma, so this is actually, if you follow these nerves here, this is the internal auditory meatus, and then there's the internal auditory canal just beyond here. There are 4 nerves that make up the internal auditory canal. And these are the facial nerve, the acoustic or the cochlea, the inferior vestibular and superior vestibular. So these 3, as I'm sure you're aware, make up the vestibular cochlear nerve, which is the apicranial nerve. But a vestibular schwannoma, so acoustic neuroma, which is another name which I'm sure you've heard for it, is actually a misnomer. So because acoustic neuroma sort of implies that the disease process is of the acoustic nerve or the cochlear nerve, which it isn't. In most cases, it's actually 95% in cases, it's the inferior vestibular nerve that has this benign growth occurring on it. And as well as that, it says it's in a neuroma, but neuroma means a growth on the nerve, whereas these are actually schwannomas. So I hope you remember Schwann cells, they line the nerve. It's a disease process mainly of the Schwann cells of the inferior vestibular nerve in most cases. And the problem with these are that it's compression that you're worried about. So if you think this is in a space close to like the cerebellum, it's in a small junction. When you have this growing, it'll press on the other nerves. So if you imagine it presses on the acoustic nerve, it'll affect your hearing. If it presses on the other vestibular nerve, it'll affect your balance, causing vertigo. And if it presses on the facial nerve, it can cause all the problems of facial nerve palsy that we previously discussed. So if I go back to some of the symptoms, you have a sensorineural hearing loss, the facial numbness, the dizziness, as well as tinnitus. And these can all be attributed to the compression factor that we just talked about. There is a condition called neurofibromatosis type 2, which has a strong correlation with vestibular schwannomas bilaterally, because it commonly causes these paragangliomas all over the body. Investigations for this condition, you do an audiogram and see this sensorineural hearing loss, and you do a gadolinium enhanced MRI head, which is a gold standard to sort of detect any vestibular schwannomas. And then here we have a cut. So this is an axial view of the head. So you can see the nose coming down here. This is the cerebellum. So normally, here's the ear. And normally on this side, you see it's normal. There's a straight line almost from the cerebellum this way. Whereas on this side, this should be a straight line from the cerebellum. But actually, there's this big inpouching pressing into the cerebellum. And this is actually a vestibular schwannoma. Okay. The management depends on the size of the tumor. So if they're very small, I've taken this from the BMJ's best practice, but if they're very small and it's not growing, you can just observe it. But if it is growing, then you want to do either radiotherapy or surgery. For surgery, they go into the mastoid, so behind the ear, and you access it through there in most cases. If it's a bit bigger, then obviously your management changes. And then if it's really big, so 3 centimeters, then your first line will be surgery. Cholesteatoma is the next condition we'll talk about. So this is a locally destructive expansion of stratified squamous epithelium within the middle ear. So this is skin cells basically that are in the middle ear. And how it presents is very foul smelling discharge. It's diagnosed clinically and on otoscopy, so when you look in the ears. So this is actually another misnomer because it was originally named cholesteatoma, but that was because when they first discovered, they thought it was cholesterol crystals because it was like pink crystalline thing in the ear. But actually it's not crystals, it's just skin cells. And normally when someone develops cholesteatoma, it's in the attic. So it's in this top bit of the middle ear. And as I'm sure you're aware, that's really troublesome because it can erode into the mastoid, it can erode through the ossicles, out through the tympanic membrane, and actually into the brain as well, and cause abscesses and cause meningitis. So it is a worry that it is in most cases needing surgery to remove. So this is on otoscopy. So you're finding this big, nasty lump of thing is in the attic of the ear. So here's the handle of the malleus. And then you see this is a normal eardrum. Just above that, you have this eroding through the top, which is cholesteatoma. The investigations, you do audiology, so you affect the hearing, and you do CT of the petrous temporal bones. So this is a coronal view. So if you imagine you've cut straight through someone's face, you see the left and the right side. To give you some bearing, this is your tympanic membrane, this is your ear canal, and then because it's a slide through, these are part of your ossicles, so your little bones in your ear, and then here's some of the cochlea, so you know, like the snail-like thing. So here, if you look, so tympanic membrane, and then here are your bones, so up here is the attic, there's nothing in here, it just looks like air. And then if you go on this side, tympanic membrane here, so then you can see your ossicles here, and there's this big dark looking shadow thing. So this is a cholesteatoma on CT. Management, usually surgical resection, so canal wall up mastoidectomy. So they go in behind the ear, and usually they keep the mastoid in place. They try not to just shave the mastoid away because it keeps some of the integrity of the middle ear. But that's not important for med school level. We don't really need to know that. Next thing we'll talk about is otitis media. So this is, I'm doing acute otitis media, chronic's a bit different. So acute otitis media is inflammation of the middle ear. It's usually due to infection, and 90% of children will have had an episode by the age of 2. Most of the time it's viral cause from the nose or the pharynx because it travels up the eustachian tube into your middle ear. And then this is more common in kids because their eustachian tubes are shorter, wider, more horizontal, and they have immature immune responses. They're more likely to get infections. The causative organisms are the same as the ones that cause infective exacerbations of COPD. So Haemophilus, Strep, Moraxella, they all commonly cause this otitis media. It presents with atalgia, so ear pain, fevers, deafness. You have a bulging red tympanic membrane when you look in the ear, and that's because you have all this pus filling up your middle ear space and pressing your eardrum out. And then some purulent discharge as well when your membrane perforates. And there's something they'll ask you in MCQs a lot. To say a kid complains of pain, and they might have fevers and they can't hear as well in a certain ear, but then after a while the pain just stops and then they have some discharge, and that's probably because the pressure has caused a perforation in the eardrum, and then that pus starts to leak out. It's clinical diagnosis, and here's an example on otoscopy. So this is really, I don't know if you've looked in many ears before, but this is a very bulging eardrum. So this is quite red and it's really pointing out towards you. So that shows there's a lot of stuff in that middle ear. The management, usually this will resolve. So normally it's just analgesia, so it's regular paracetamol, ibuprofen. Antibiotics, you don't normally want to give it to the patients because it barely changes their outcomes unless they've got a really bad infection. So say they've gone 24 hours with no change and they're really unwell, needing hospital admission, then you consider antibiotics. And then surgery if any of the complications arise. Next is otosclerosis, and this is a word that comes from Greek originally, and it means the hardening of the ear. So what happens is you have altered bone metabolism in the otic capsule. So there's your bones, your malleus incus and your stapes, and you have loads of resorption, so breaking down of bone, and loads of new deposition of bone. So that's the osteoblasts and osteoclasts. And it affects mainly the stapes, so the foot plate. So here's a picture, hopefully showing it quite well. So your malleus rhynchus and your stapes. Here's your promontory, and your oval windows here. And then basically the stapes normally moves forward and backwards, giving that kinetic energy. But you get this otosclerotic bone here in this certain population of patients that it builds up and then basically causes a problem with your hearing, usually a conductive problem. And normally there's endochondral calcification, which is what forms these bones. And that's normally complete by 1 year of age. And there's very little remodeling thereafter. However, when people have this condition and they have this mass remodeling, you get very well increased vascularization of the bone. It becomes increasingly mineralized, and there's just an extra formation of it, and it can actually affect all of your ossicles. Let me move on. So it's generally more common in women than men, and in the 2nd to the 5th decades of life. And there's an autosomal dominant pattern of inheritance, but that it's important to also say that actually 50% of patients have no family history whatsoever. And there is some research that suggests there's an increased risk in pregnancy, and that the hormone balance in pregnancy increases your risk of developing this condition. People normally present with bilateral hearing loss, and it's conductive, and then maybe some tinnitus. And there's also this sign called the Schwartz sign, or the flamingo sign, which is, like I was saying, the very well vascularized bone in the middle ear. This is this red thing that you're seeing behind the tympanic membrane. So there's loads, it's very, very vascular, and it's not normally something you'd see this red over the oval window. So that's a sign to remember. And it's diagnosed by ENT surgeons. And then basically it's just a diagnosis of exclusion, because you're just ruling out other potential causes. The management, you can just do nothing for it. You can offer hearing aids to the patient, or you can do surgery, so such as a stapedotomy. This is an example of this. So in this case, they've done a stapedectomy. So they've removed the whole of the stapes for whatever reason. Maybe it was diseased from the otosclerosis. But what happens is you basically use a prosthesis, and they've just attached it here to the incus. And then this will just serve the stapes' role. And 80% of patients who've had this type of surgery report improved hearing. So it is a very successful operation. Next is Meniere's disease. So Meniere's disease is a set of symptoms, and it's basically chronically progressive destructive disorder, and it affects both your labyrinth and your cochlea. So it affects semicircular canals, your cochlea, and it causes permanent hearing loss and damage to your problems with your balance. It's relapsing remitting usually, so the people will complain of having this problem for up to about 2 hours from about half an hour. And it's also interchangeable with its name, endolymphatic hydrops. Patients have these 4 signs usually. They have hearing loss, tinnitus, vertigo, and oral fullness. So they'll just complain of a feeling of fullness in their ear. So again, this is just the normal ear anatomy. But then here's the cochlea, snail-like thing, and here are your semicircular canals. And this, what happens in Meniere's is you have too much fluid, and it basically leads to increased swelling and then increased pressure in your inner ear. So if you look at these are semicircular canals, and if you have swelling of the endolymph here, you can have problems with balance going down the vestibular nerves. Here's your cochlea. So if you have swelling here, you have problems accessing the hair cells, the cochlea, and this will affect your hearing with the sensation going down the cochlear nerve. So investigations, so audiometry, they'll have a sensorineural hearing loss, and then you just rule out other things. And the management generally for Meniere's is you want to reduce fluids, so lower salt intake diet, give them diuretics can potentially help, but there's been some studies that say that it isn't actually beneficial. And then other than that, you're just sort of controlling symptoms. So for the vertigo, give them antihistamines and benzos to sort of calm them down. For tinnitus, it's like you can give them maskers that create small amounts of sound so that it sort of blocks it out. or tinnitus retraining therapy. For the hearing loss, give them steroids, and you can also give them intratympanic gentamicin or surgery if it's very progressed disease. Next, we'll go with benign paroxysmal positional vertigo. So this is a peripheral vestibular disorder, and it's sudden short-lived episodes of vertigo elicited by specific head movements. So patients will complain of being really dizzy, usually when they look upwards. So in questions, they'll normally say they've looked up to a bookshelf or whatever, and they just got really dizzy. And the pathophysiology of this is you have a migration of these free-floating canalith particles. So they're called otoliths. So they're basically these calcium crystals that I think is explained really well here. So usually they'll sit in the utricle, and they're important as they sit on some hair cells that help you gauge gravity and your balance. And what happens is when someone has trauma from whatever cause or for other reasons, these otoliths can actually fall out of your utricle and enter your semicircular canals, most commonly the posterior semicircular canal as demarcated here. And then what will happen is you have these particles going around this really important balance structure, which can make you really dizzy when you move your head in certain directions. So brief positional episodic vertigo. Investigations, so everything's usually normal except for the Dix-Hallpike test. And the way to remember this easily is for diagnosing benign paroxysmal positional vertigo, it is the Dix-Hallpike test. And I remember that because D for diagnosis, because there's the Dix-Hallpike and there's the Epley maneuver, which always seem to come up in exams. Dix-Hallpike has a D for diagnosis. That's how you diagnose BPPV. So this is how they do it. You basically hold the patient's head and you lay them down on the end of the bed with their head slightly rotated to 45 degrees. And then what will happen is if they do have these otoliths in the semicircular canals, they'll get a nystagmus. So they'll have a nystagmus towards the side that's the expected to have towards the ear, that has the otolith in. So if we turn the head to the left, they'd have either a twisting, so a torsional nystagmus, or a horizontal nystagmus, depending on which semicircular canal the calcium crystals lie in. Management, usually most people are actually asymptomatic after 6 months. So mostly it's just educating the patients, telling them what this is and reassuring them. And really beneficial are these reposition maneuvers. So Epley maneuvers is one example, but this is a different one called the particle repositioning maneuver. And you basically do a really similar thing to the Dix-Hallpike, except for when you lie them down at 45 degrees, you then want to turn them over completely to 180 degrees. And that basically will turn the head enough that the particles will fall back out into the utricle, which is quite interesting. Last few conditions, and I've got a few MCQs. So I always thought these two were quite interesting. So vestibular neuronitis and labyrinthitis, because most people I talk to can't elicit a difference between the two, but it is a quite simple way to distinguish. So vestibular neuronitis, inflammation of the vestibular nerve. So you get vertigo that lasts for days usually, and this affects their lives quite badly, to be fair. Most cases are viral, so they'll complain of having a cough or a respiratory tract infection, and then getting this problem with vertigo. So as shown here, so these are semicircular canals. This is your superior and inferior vestibular nerves, and that's your cochlear nerve. So they'll get sudden onset and really incapacitating like vertigo, and then nausea and vomiting. And the management, most cases resolve in a week. You can give them vestibular sedatives, so like prochlorperazine, and then vestibular rehabilitation exercises, which is different like movement exercises and positional things that will help them deal with that if like the prochlorperazine hasn't worked. And in these kind of things, when you have a balance problem like this that does self-resolve, you want to avoid giving medicines for too long, because you want your own like compensatory mechanisms to be able to start working again. And if you keep adding different medications onto patients like these, it doesn't allow the body to correct itself. So this is what I believe is the last one we'll go over, labyrinthitis. So inflammation of the labyrinth, the infection affects both branches of the vestibular cochlear nerve. So if you look here, as well as affecting the semicircular canals, it also affects the cochlea. So this is the way to tell between these two conditions, because although both present with vertigo, labyrinthitis is the one that presents with hearing loss and tinnitus. And this is because you have the cochlea that's infected or affected as well. So if you have a cochlea affected, it's more likely to be a whole labyrinth problem. And then that's why they have hearing loss. It's a diagnosis of exclusion, and the management depends on whether it's a viral or bacterial cause. Again, you can give them vestibular sedatives or benzodiazepines, and then potentially antibiotics or antivirals if you know the cause. Okay. And I've got 5 MCQs, I believe. I'm not sure if anyone wants to actually answer them in the chat or whatever. I can't see that, but I'll put the questions down below and then wait a little bit and then
I'll read them out. That's fine.
Okay. Do you want me to read out?
Yeah, go for it.
Okay. So Marcus is a 41-year-old man who came to see you 6 weeks ago with vertigo following a viral infection. You diagnosed vestibular neuronitis and prescribed a course of prochlorperazine for symptom control. Marcus comes to see you today with ongoing vertigo. This improved with prochlorperazine, but he still experiences attacks of vertigo, which usually last hours. There are no new symptoms and neurological examination is normal. Which of the following is the most important for ongoing management? So either arranging an urgent hospital admission for this patient, continue the prochlorperazine long-term, prescribe a short course of promethazine, prescribe beta-histine, or refer for vestibular rehabilitation exercises. How long should I give?
Just give a couple of seconds, or if you don't understand any part of the question, like just you can say it out loud or put it in the chat. We'll just pretend it's A, B, C, D, and E.
Yeah, I really should have done that actually. Okay, do you want me to move on or?
Any ideas? Go on, you can give the answers then, maybe next time.
Yeah, that's fine. So in this case, it's refer for vestibular rehabilitation exercises. So as we just talked about, you don't want to give medicines for too long in someone who's had something like a vestibular neuronitis. You want your compensatory mechanisms to work. So just giving them exercise is a good thing to help improve that. Next question. 25-year-old woman presents with recurrent attacks of dizziness. These attacks typically last around 30 to 60 minutes and occur every few days or so. During an attack, the room seems to be spinning and the patient often feels sick. These episodes are often accompanied by a roaring sensation in the left ear. Otoscopy is normal, but Weber's test localizes to the right ear. What's the most likely diagnosis? So acoustic neuroma, vestibular neuronitis, BPPV, multiple sclerosis, or Meniere's disease. I don't know if anyone's interested in having a crack at the answer. I'll go through it, if not, either way.
Just wait a second or two. Katie says Meniere's.
Yeah, nice.
Well done,
okay, so it is Meniere's. And the way you can sort of work this question out is, obviously, if you know your timings of disease, it makes it a lot easier. But this patient has recurrent episodes of dizziness. So they're having this like vertigo where the room's spinning, and they've got a roaring sensation in the left ear. So you think there's a problem in the left ear, but a Weber's test localizes to the right. So if there's a problem in the left ear and it was a conductive problem, then Weber's would localize to the left. Whereas Weber's localizes to the right, which means it's actually a sensory neural hearing loss or a sensory neural problem in your left ear. And the only one that would fits that picture is Meniere's. Okay. Next question. A 4-year-old is brought to the general practitioner by her mother. She's been distressed with ear pain for the past 14 hours. She's constantly touching and pulling at her ear, which is a very common complaint in even GP land. While she's sat in the waiting room, her mother notices a discharge of foul-smelling fluid from the ear, following which the pain resolves. What is the most likely diagnosis? Acoustic neuroma, otosclerosis, preauricular sinus, acute suppurative otitis media, cholesteatoma, long-standing perforation of the pars tensor. I'm not sure if there's another one. Otitis externa. Is there another one? Do I risk it?
I don't think there'll be another one. It looks like a small
Yeah. All right.
We actually already have an answer. Katie says cholesteatoma.
Cholesteatoma. Okay. Have we got any other?
No, go on. Oh, otitis media.
Okay. Yeah. So I can see why you said cholesteatoma, but in this case, it's a acute suppurative otitis media. So the way that you tell this is, so they've had this ear pain for the past 14 hours. She's pulling at her ear, so obviously there's a problem going on in the inner ear that she can't get to. So it's probably a middle ear problem anyway. And that, yeah, there's the foul smell and discharge does make you think it could be cholesteatoma, but when this discharge happens, timing's really important here. So when this discharge happens, the pain stops. So in cholesteatoma, the pain wouldn't stop. If they had pain at all, it wouldn't change. Whereas what's happened here is they've had this this pus fill in the middle ear, so that it's got really painful for the child until the tympanic membrane's perforated, and then the pus comes out, which is the discharge, and then the pain resolves because you lose that. There's no pressure anymore in the middle ear. So that's why that's otitis media. Next one, a 34-year-old lady presents with long-standing offensive discharge from the ear, and on examination is noted to have reduced in a hearing of 40 decibels compared to the opposite side. What is the most likely diagnosis? Any takers?
Not yet. A second or two. Yeah, go on, give the answers.
Yeah. So this is a cholesteatoma. And you can basically get this from 4 words, really, or I guess that counts as 1 word, 3 words. So long-standing offensive discharge. So they've had a change in their hearing and they've got this discharge that's lasted for a long time, which means it's not going to be an acute otitis media, and it's not going to be any of these other things. So long-standing perforation wouldn't cause offensive discharge unless there was another disease process going on. And otitis externa doesn't cause that. So the only one of these options that makes sense here to cause long-standing offensive discharge is cholesteatoma. And then obviously it's eroded into the ossicles to have this much of an effect on the hearing. Okay, this might be the last one, I think. Oh, is that all of them? Maybe one more? Ah, crud. I knew I'd lose on one. So a 27-year-old female presented to a GP after one prolonged episode of dizziness. She felt that over the course of 2 hours, she was losing her balance easily, as well as vomited. She vomited 3 times. She has no other neurological symptoms and no past medical history. On examination, the only notable finding was a horizontal nystagmus of the left side. What's the most likely diagnosis? So dizziness over 2 hours, vomited 3 times. So she's really not feeling very well. Any takers?
Oh yeah, if you didn't see it. Oh yeah, viral or vestibular neuronitis.
Yeah, nice. So the way you can tell that, which I'm sure you've gathered, is that they've no other neurological symptoms. The only finding was a nystagmus, which means the hearing's normal. And if the hearing's normal, it's not going to be a whole labyrinth affected. It means it's just the vestibular nerve. But yeah, it's very debilitating and really affects patients. But that's everything. So thanks for coming to the talk. I hope that's helped in terms of it's covered. I know it was a rush, but it's covered. I think there we covered like maybe about half of the very commonly asked questions in ENT for finals. And I think they don't really ask very many complicated questions for ENT in finals. It's more just sort of little questions like the questions I've just asked you there. They ask that kind of thing. Just like, do you generally understand the conditions to a reasonable level? And if anyone has any questions that they don't want to put on here or want to contact me in the future, my email's there.
Thank you. That was really good.
Thanks for having me.
I think in finals, like it's the surface level stuff about a lot of things. Like they could ask you about any of the conditions, but it would be surface level.
Yeah, exactly. Should I stop screen sharing?